reasonably straightforward consensus that high-risk patients need some extra treatment. An important point to remember is that we are still not curing low-risk patients, so we should not do less for them. But for high risk, we may be inclined to take more aggressive approach, and so allogeneic transplantation, use of CAR T cells, or giving more consolidation treatment or longer maintenance treatment with 3 drugs might be some of the things which we would want to do for high risk, that because of toxicity and other concerns, we don't do it for low risk. So that's one aspect. But the second aspect of this debate was that now that we do genomics and we do mutational analysis and other things, do we now go for targeted treatment? So if a patient has a BRAF mutation, should I give a BRAF drug, a targeting drug? Or if patient has a RAS mutation, should I use a MEK inhibitor which will target those cells? And there was a very interesting debate and discussion. The consensus is this, that number one, we should at least evaluate the mutational profile so we know what patient has. There are some mutation for which there is a drug. So RAS and RAF, maybe IDH mutation and few other less frequent mutation. And this may cover almost 50% of the patient or more. The problem is that myeloma genome is so unstable and there are so many mutations that if you use one single targeted drug, there will surely be development of resistance. So sort of consensus of the debate was that it is good to use targeted drug, but we probably need to combine them with other our more broader acting drugs. So use both combination, not just the targeted drug. And the final point in this discussion was also that measuring mutational profile of patient or genomic profile one time is not enough. We need to measure it multiple times, mainly because genome changes. So you can have it at a diagnosis, but we can then also need to do it subsequently during the treatment and even when patient relapses.